Awesome. All good.
Okay. Hello, everyone. My name is Adam. I'm going to be doing a planning tutorial for you all. I'm here with Cesar and Claire, two of my good friends and really good physicists. They'll be chatting with me throughout the process, asking questions, and sort of bouncing ideas off of me. So here we go. So I'm planning a pelvis plus periaortic, and it's got in the pelvic nodes, so the whole pelvis is going to 45 gray. This pelvic node is going to 55 gray, and then these periaortic nodes up here are going to 50 gray. And the doctor in this case wanted the GTVs, you can see here, I can turn them on, to be covered by about 107%. So here and down here. So we're really going to about 4 different dose levels here. The other thing is, you might notice that this periaortic node in this case is only going to 50 gray, whereas the pelvic nodes are going to 55. And that's because in this particular plan, there's actually an additional boost of the periaortic node. These are have more recurrences typically than other nodes. All right, so I'm going to be planning by a particular method, which will be covered in the RCC curriculum in the PowerPoint presentations covered by Cesar. And the idea with this method is that hopefully, if we design our contours properly and don't have any conflicting arguments, that we'll be able to get the plan done to a high quality within 1 iteration. At most, I'd like to see 2 iterations. Now, it's been about a year since I've planned, so bear with me if it doesn't go quite as planned, but here we go. So I'll discuss a little bit about the contours. So the first thing is, we'll want to, so if you notice here, there are a bunch of contours. This is a plan that I just took from someone else, so it has a bunch of contours that I may not use. So just pay attention to the ones that I'll actually use. And because there are so many contours in here, I didn't necessarily go by a perfect naming scheme, but you'll get the idea. So the first thing is to look at any overlap. So PTVs 50 and 55 are alone, but PTV-45 has these overlapping it. And so what we've done is created this subtraction. So this is the PTV-45, just a DVH structure. And so it subtracts out PTVs 50 and 55. And that way it doesn't skew the DVH results, okay? And then the next thing that I want to do, so in order to, what we want to do is we want to have distinct dose levels, 4 distinct dose levels. In order to do that, in this case, actually 5 distinct dose levels. In order to do that, what I want to do is I don't want too many hotspots in each PTV. So in this case, it's primarily 1 larger PTV, so I'm more worried about the hotspots here. And so in order to do that, I will subtract out a margin, so it'll be the same DVH structure, but I'll subtract out an even bigger, a little bit of margin around the higher dose levels. And that way, in the optimizer, the whole idea is to have no conflicting arguments in the optimizer. And so if I'm abutting 45 with 55 down here, what's going to happen is that tail of the DVH, we won't know if the tail, those higher doses, are all close to this structure, or if they're just sprinkled out throughout the structure everywhere. So in order to say that we only want max doses up to we want the highest doses just surrounding here, we'll subtract out a little bit of the margin. So there are a couple rules of thumb. So with organs at risk or smaller organs at risk, something like a rectum, you can have a dose fall off of about 10% per millimeter. So I would look at the 50% isos line should be about 5 or 6 millimeters away at its closest point. Or if you're looking at dose fall off sort of around a structure, you're looking more at about 5% per millimeter. So if we want to know this margin that we want to apply, Well, we would just do PTV-45 divided by PTV-55, 81%. So it needs to fall off about 19% or 18% in this case. And so if you look at 5% per millimeter, it's about 3 millimeters. So I've done just that. So if we look at this RA45 max, here it is. It's 3 millimeters away. So now I know all my hotspots will be confined here. Anything that's even higher than what I envisioned for these hotspots should be confined within this 3 millimeter margin. Okay, and so this sort of acts also as like a ring. So I won't even have a ring around these higher structures because I'm limiting dose with the max for this larger PTV. And then I will do the same with these periaortic nodes. And again, you can use your calculator and you can say PTV-45 divided by PTV-50, 90%, so 5% per millimeter, 2 millimeters. So I've done a 2 millimeter margin around this PTV. Then what I'll do is I'll create a ring. I'll create a ring 1. Make this bigger. And again, I give a little bit of a margin so that I don't have conflicting arguments. This one I want covered by 95 to 100%, right? But this one, I'll want something lower to confine that dose. If I put them on the border, then I'll have 100%, 100%, and it becomes sort of a conflicting argument. So I give a little bit of a buffer. That way I can have 2 separate arguments for the optimizer. So this will be between 95 to 100% at this boundary. And this one, which I've done 3 millimeters away, 5% per millimeter, I'll put a max dose of 85%. And we will want to make these a little bit bigger around these PTVs. So here we've got, which was not done before. I apologize, I should have had this set up earlier. So it's still the 3 millimeters. So if we want to know exactly how much to subtract this one, so this ring is going to 85% of 45 gray to 3825. But it's close to PTV-55. So how much of this is, what percent is that for PTV-55? About 70%, so it needs to drop 30%. So 30 divided by 5, 6 millimeters. Okay, so we'll drop it 6 millimeters away from PTV-55. I'll go into contouring and do that in a second. And then for PTV-50, it needs to drop 25%, so that's 5 millimeters away. So let me quickly go into contouring, and I'll fix that real quickly.
Adam, while you're opening that, can I ask a question about the thickness of the ring that you've just drawn? So how wide is that around your PTV?
Good question. So I do it 1 cm, the actual thickness of the ring, and then I'll actually do a second ring. Sometimes 1 ring is actually sufficient. I won't even do a whole second ring, but it's so quick and easy. I'll usually just throw it in there. So quickly.
And if you do the second ring, you also leave like a gap between the first ring and the second?
That's a good question as well. I'll show you that in just a second.
Sure.
Okay, looks like I've already got a temp. Add a temp 2. So this will show you how I actually do this. So I'll make a margin. For PTV-50, we said that was 5 millimeters. We'll call this temp. And for PTV-55, we said we want that be 6 millimeters. Call this temp 2. And then we'll do a Boolean operator, and we will subtract. We'll do ring 1. Subtract. Temp and temp 2. And we'll make this ring 1. And you can see it just subtracted out a little bit more gap right here around this hotter PTV. Okay, and to show you what ring 2 looks like, it abuts ring 1 and just another cm. And ring 2 now is about 1.3 cm away. So if you think about it, 13 millimeters times 5. It says it's a 65% drop off, but that's obviously not going to happen. So I'll usually limit this to, I'll just say it'll drop off about 40–45%. At some point, that 5% per millimeter doesn't hold. It can go closer to 3% per millimeter as you get a little bit further away. And if you look at 3% per millimeter, that's closer to, you know, what I think is achievable. So I'll limit this dose to about 65%, 60 to 65%. Let me save this and go back to my external beam. Okay, and then we'll take a look at a couple more structures before we dive into the plan. Again, we've got these PTVs, but we're also covering GTVs. So again, we'll make max structures for that. And this is a 7% hotspot. And we've got a 2 to 3 millimeter gap. And the same max structure we'll do for those other nodes so that we can separate just the hotspots in the GTV and not the hotspots in the surrounding area. Okay, so we do that for both GTVs as well. The other thing that I'll do in all of my plans, take these ring structures off, is you want to expect where the optimizer is going to struggle the most. And we turn these temps off. So the optimizer is going to struggle on the edges of the PTVs, right? Because you're lowering dose with rings all around. You're lowering dose right next to organs at risk, bowel, rectum, bladder, kidneys, duodenum, so forth. So it's going to struggle all around the periphery. So you think about that ahead of time. If you know the optimizer is going to struggle there, let's go ahead and create an edges contour. So this is the outermost 5 millimeters of the PTV. Because I know the optimizer is going to struggle more here, so let's go ahead and create a structure to optimize just that outer edge. You can call this a rind, edges, but that's what that is for. The other area where it's going to struggle, these nodal chains up here, right? These are tougher areas for it to cover. Same thing with head and neck cases, the nodal chains in head and neck cases. So I always make these corners. Here they go, just the corners. Nothing else, corners front and back, corners up here, and it doesn't cover anything else. Just these little areas where I know it's going to struggle, so I can put those contours in advance. And then
Adam, why does it struggle in those areas?
Just because it's a little bit more difficult. That's not a very good answer. So if I'm optimizing on something like this, right, it's quite easy. I mean, you could almost have MLCs open the whole time and just doing an arc around, like a dynamic conformal arc, and you could get pretty good coverage here, right? It would be hot in the middle, but you get the idea that it's sort of easy to cover here. But when you get these jagged,
it's a weird, it's a not circumferential shape, so it's like weird with horns there, so probably.
Yeah.
Yeah.
Exactly. So I'll be limiting dose inside of here, limiting dose outside, trying to make it conformal. These sharp points, it's just more difficult for the optimizer to push that dose in there conformally.
And those structures, you more or less just by experience, for example, when you show the ones that just how low you go, how posterior you go on the border of that corner?
That's a good question. Good question. So the edges, I do 5 millimeters every time.
Yeah.
The corners, yeah, just a little bit of experience. You can just look at it and you can think, there's no right or wrong answer, to be honest with you. I could have drawn them cut off here and just even smaller, probably would have done the job. The bigger the contour you draw, the less it's going to focus on all aspects of that contour, right?
Right.
So one of the reasons that this PTV-45 is so difficult is it's huge. It goes all the way here. It's just enormous. So it's sort of difficult to cover the whole thing. And so the idea is the smaller the region, if I just had, if I just contoured 4 slices right here, well, the optimizer could easily achieve whatever I wanted it to do on just 4 slices right here, because it's a small amount of volume, which means fewer pixels, fewer voxels that are out of the tolerance that you put into the optimizer. That'll have a bigger impact. So the smaller the volume, the more it will focus on it. So you don't want to make them too big, but you don't want to make them too small where, okay, now I'm missing some stuff here. So it's a little bit of experience, but the idea is to try and keep it as small as you can while focusing on points that you think might be more difficult for the optimizer.
Does it also depend on the distance from the isocenter?
Not really, in my experience. That has some other areas of impact in terms of deliverability and DLG and that sort of stuff. But in terms of the optimizer working, I haven't seen that as a factor.
And you only do these corners and edges on the lower PTV dose, correct? In this PTV-45. But for example, if you have weird shapes on the other, I don't know, I'm thinking of a head and neck with and head and neck, you might need to do it on the other levels too, maybe.
Yep. So sometimes in head and neck, I'll do it on, say, a PTV-54, and I'll also do it on a PTV-59 for, so wherever I see these corners, especially head and neck, you'll see it on multiple dose levels. I'll put those corners in. That's a good question. And then I did it on this case, honestly, just because they were already in here for me. Typically, so if I pull up the bladder, for example, typically I'll actually just optimize usually on the bladder without creating any additional structures. And the fact that I have these edges, it allows me to lower the DVH on the bladder and still keep my PTV coverage. So that's a viable option. Or you could, if you want, you can do Boolean operators and subtract out the parts of the organs outside. So for example, right here. Either option is fine, honestly. They both sort of work with this method. You can either optimize on this crop structure, or you can optimize on the whole structure. When you see me go through the optimization process, it shouldn't really affect either way that you do it. In this case, I'm going to optimize on this crop structure. They were already created, and I'll just use it that way. But the same process you'll use either way. In this case, all my cropped organs are 3 millimeters away, the same as my rings. So they'll start at 85% dose. And there's a crop structure for basically all of these. So there's one different one. In this case, instead of all of the bowel, I just did this middle bowel. just because I wanted to focus on here a little bit more than just everything. So here's everything. And that was just a preference to give it a little bit smaller region where I think I could reduce more dose throughout this region, which would be more helpful for the patient. So we've got, if we go up top, I'll show you the rest of the organs at risk, and then we'll start. So we've got the duodenum as well. And kidneys. All right, so lots and lots of organs. The way that I'm going to show you how I plan is I'll look at my DVH constraints and I'll see what do I need to achieve, and I'll make sure that I achieve that. If there are areas of overlap or things that I can't achieve, I'll make note of that. But then if I reach tolerance, I don't just stop there. So what you'll see on this is I'll push as much as the optimizer will allow me to push. So even in this case, it's going to a lower dose, 45 gray. A lot of these organs at risk are well below tolerance, but that doesn't mean that we can't push them. So you'll see that I'll push on everything, no matter how far below tolerance I already am. And I think that's an important thing, especially when you get into higher doses, things like head and neck, and the tolerance dose of, say, parotids, a mean of 26 or 24, whichever is used. These are all probabilities, so the lower that we can get, the better.
Adam, we question about the bowel. So you have the bowel, you have everything small and large together? And
yeah, so in this case, I've got small and large together. This doctor, where is it? Contoured a bowel loop. I mean, this was from a couple years ago, so I don't remember all the details. Where is it? This doctor only contoured the bowel loops near the PTVs. I mean, near these higher dose. Where is it?
Yeah, because you know that they're going to be below tolerance because of the doses you're going.
Yeah.
Yeah.
Okay, so here, it's up here, I think. Okay, so for example, I think this doctor only contoured this bowel loop here. I don't even know where it is on these structures. I'm sorry, it's somewhere.
Yeah, no problem. It just
and so
makes sense because of the doses that you're going, so you know that you're going to be under top.
Exactly. So this one, I think the doctor just wanted to keep the max bowel loop to 55. And again, so there may be some differences in how a doctor contours, what structures the doctor contours, but for a planner, the ideal would be the same, no matter what the contours are, I guess. Do you guys have any other questions about contours before I jump into the actual plan?
You don't tend to contour much above and below your PTV?
No.
Yeah, great.
Yeah, so I pretty much rely on organs as they are. Like I said, in this case, I did cropped organs, but you can do the same process without even cropping. You should get the exact same results. So I like to focus on just the optimizer working and trying to limit how many conflicting arguments there are, and focusing on these little areas where I think it'll need help in advance.
And for just one more question for the core and core, do you do PRVs?
Good question. Yeah, so in this case, I think it was let's see, I think it was a 5 millimeter PRV. Yeah, it looks like a 5. Measure real quickly. Yeah, 5 millimeter PRV. And so we can see in this case, you know, PTV-45 is actually going into the PRV, and it's close to the cord. So it's a tough case. And again, these are good things to look at before you start planning. So you know, okay, I'm not going to push this PRV down to, you know, say 35 because it's right there. So having this in mind is a good idea. Okay.
Would you ever, sorry, would you ever reduce your PTV margin rather than letting it go into the PRV?
Yes. So that's a very good point as well. So these would be discussions to be made with the doctor ahead of time. So you're right. In this case, I would probably ask wherever this overlap is. I'd say, look, my PTV-45 is going right into the PRV of my spinal cord, or is it spinal canal? Can't tell which one it is. I think it's spinal canal at this point. It's going right into the spinal canal. And I would ask the doctor, do you want me to shave PTV and make sure I spare this, or cover PTV and get this as low as possible? And that's a question that I would ask the doctor ahead of time. So this is in particular importance for things like head and neck cases. I'll ask questions on a lot of the organs at risk every single time. So the institutions where I've worked, I've tried to ensure that we have some sort of priorities on dose objectives. So typically in something like a head and neck, you'd have the optics would be spared, the brainstem and spinal cord spared as first priority. Second priority would be coverage of PTVs. Then third priority would be other organs at risk. And then if the doctor wanted to deviate, the doctor would need to put a note. So for example, maybe the doctor would want to, the cochlea are on the edge of PTV-59, and maybe they'd say, you know what, I'm okay sparing the PTV portion of 59, cover the CTV, but try and reduce my cochlea down to a mean of 45. Or they might say the same about parotids, left and right. Maybe there's high risk volume near the right parotid, and the doctor asked to spare the left parotid as much as possible, allowing you to sacrifice PTV but cover CTV. You know, these are the sorts of discussions and questions that I would ask the doctor beforehand. And same with this overlap of PRV and PTV-45. Good question, Claire. Oh yeah, I forgot to set up the beams with you guys. So
that will help.
Yeah. So I've already set up these beams. So they're let's see. So in this case, I'm looking at efficiency. So in the majority of cases, I try and use 2 arcs only as much as possible, just to get patient throughput, especially for some of you all with lots of patients and not enough time. Let's get them in and out as quickly as possible. So if you can do 2 beams, do it. Sometimes there's the need for more. Also, you need to think about your particular machine and how you're going to image and what you're going to image. So in this case, I put the isocenter sort of centered, SUPIMP, but you need to make sure that you'll be able to image what you want, how you want with your particular machine. So this could differ from machine to machine. So for example, for this pelvis plus periortic, typically, well, you'd want to ask the doctor what sort of imaging and where. So in this case, the doctor was interested in the bowel loops up here, right? We showed that bowel loop that came close to this PTV-50. So they wanted a CBCT up here to look and see if the bowel loop stuck during surgery or after surgery, if it got attached, or if it was moving some, and they could see that by imaging day to day. Sometimes if you got bulky disease inferiorly, you'll want a CBCT on the bulky disease, and maybe just use AP-lat films on the bony structures, assuming that your periortic nodal volume will follow the spinal cord, follow the vertebrae. So you need to think about what's going to image, how your actual machine works, and if your isocenter placement will allow you to image how you want. So you could put this isocenter further down and just have asymmetric jaws. In this case, I put it in the middle infant soup. The other thing is, on this particular machine, which is a true beam, we're only able to open the jaws, I think it's 15.6 cm exactly, before the leaves can't travel any further. So if I had opened these jaws way out here, big open jaws, well, the MLCs might optimize and try and optimize, and MLCs on this side might get stuck all the way over here, optimizing something here, and the MLCs from this side would want to travel all the way over here to produce small beamlets, but they wouldn't be able to travel that far, so you'd be left with these big open gaps of beam. And so you can practice and see how that changes if you have, say, a 20 cm jaw or a 16 cm jaw, and hopefully you'll see a reduction of those big open beamlets. So in this case, I relaxed it to 16, and then what I would do is play it and see if it looks good. So I don't necessarily need to cover everything in all my beams I've used, but here I'd like to cover this side the whole time in this beam, and I'll cover the other side the whole time in the next beam. So I've got slightly asymmetric jaws, reversed. Right, and just in this case, a 15-degree collimator kick on both beams. I tried 20 at first, and I was missing a little, cutting off some tissue, so I moved it to 15. I wouldn't typically go lower than 15. And you can look at the other beam. Now you can see that I'm catching all of the beam in this view. Slightly missing here, but that's okay. And I've caught everything soup imp the whole time. Any questions about the beam arrangement in this case?
Looks good to me.
Yeah.
Okay, then I'll jump into the optimization. Okay, I've put some starting optimization up here already. I'll go through sort of quickly what these are. So the PTVs, I'll usually start at 100% covering prescription. So for the CTVs, I'll do a little bit higher. So I've gone like 1 gray higher than prescription. Again, CTV 100%, 1 gray higher. I started at about 200. The GTVs, again, we want this to be at 7%. So 7% of 55. About 58.85. So I went about half a gray higher. Again, half a gray higher than 7% hotspot. PTV 50. Again, 100% getting prescription. I'll do 2% lower, so 98%, just a little bit higher. Again, 100% to prescription, 98% to just half a gray higher. Then I've got these corner structures, again, 100% to 45, edges, and my 98%. So basically the same for all my PTVs. Here's my DVH PTV 45, excluding 50 and 55. Again, the same thing, 100% to prescription, 98%, half a gray higher. Organs at risk have 0 on all of them. I don't put any organs at risk in to begin with. Here are my max doses. So I'll do 0 at 3%, and that's the only one I optimize on to start with. I'll put in more as I go in level 3, as you'll see. And then just something to see, 5% for 105% hotspot. I'll do that for all my maxes. Okay, very similar for all my maxes. And I put in mean doses and upper. So here's this upper for my organs at risk that are 3 millimeters away from my PTV. And I put it at 85%. So 85% of 45 gray is 3825. That's my 5% per millimeter. And then I just put in a mean dose. This value doesn't mean anything. It's just what automatically came up with 0. Because I know that I'll optimize with means after I'm ready. I put in my rings. So this is the only other thing other than PTVs that I have objectives on. 0%, getting 85% of prescription at 3 millimeters away. And then 65% of prescription is 2925. So that's my ring 2. I'll put these at about 150. Again, nothing else on organs at rest, and then I'll use my normal tissue objective. This is eclipse only. Some of you won't have this. If so, you can think about using additional rings. You still probably won't need them, but I use this in addition. So I'll do a manual at the same priority as my targets. So I start the dose fall off 0 millimeters away from my target. This works for all 3 targets. In eclipse, this start dose means percent of your lowest upper objective. So my upper objectives are 0% of PTVs getting 103. So that ends up being 0.95 times 103%. It's really starting at like 98% of the dose of the prescription dose. Sort of a weird thing. And it drops off to 40% with this fall off factor. This has been more sort of experience. I found it to work for me, so I've just left it. If you want to know the dose fall off, how far, how long it takes, you can always do an optimization. Use your profile measurement tool, measure a profile of your dose fall off, visualize what that dose fall off is, and plug in this number until you get that similar dose fall off. It could change from site to site, but I sort of use this standard right here.
Adam, how different is that from the automatic NTO values?
I think it starts out, I can't remember what it is.
I think it doesn't start from 0. I think it starts from a little, I think.
Starts from, yeah, further away.
Farther away,
yeah. Yeah, it starts from much further away. Mm-hmm. It goes up to, I think, 60 instead of 40, and this is a much shallower fall off.
Yeah.
So usually it falls off much shallower.
Okay.
So I've made this quite steep and very close to the PTV.
Yeah.
So it's a lot sharper and closer than when it automatically comes up.
Yeah, sometimes start from 1 cm even.
Yeah, I think you're right. Okay, so.
Quick question, Adam, this is great. I mean, I like the idea that you start with just the PTVs and the rings, which is great, because that's gonna, if you got a plan that's to make sure that you're covering the PTVs without any other thing. So, but you're using the PTVs and also the PTV max also, both. Okay.
Yep.
Mm-hmm.
I'll have this intermediate dose. This will calculate in step 4. It's a different dose calculation in your optimizer as it is actually in Eclipse, which could give slightly different doses. So I'll do an intermediate dose, which will be my actual Eclipse Acuros calculation, and then fine tune it later. So I'll keep that. And I'll go ahead and start the optimization. The good thing is, if you have the same names, and you can actually create scripts for this. So you can create scripts in whatever your planning system is and do the different Boolean operators. And the margins will all be the exact same depending on your dose level. So if you have certain prescriptions that you do at your center. If you can script this out, that means you can script out the Boolean operators as well as script out these starting values here. And then basically you could, from getting contours, or organ at risk and target contours, you could have this whole thing ready to optimize in the matter of, say 15 minutes, right? If you had a nice script that goes with it. And hopefully this optimization will take about 1 hour. And hopefully, if I'm not that rusty, it should be done. And if it's not done, it would be super, super close. I never create additional contours, so I won't make like hot and cold stuff. The contours that I have here should be all the contours I need. So even if I need to fine tune something after this optimization is done, I would fine tune it slightly with the contours that I already have. I would just maybe slightly change dose values or weighting until I get the DVHs exactly the way that I want them. So here in Eclipse, we have these different MR levels. It basically gets more and more degrees of freedom the further you move along in the levels. So this is quite a coarse DVH that it's working on right now. So I think it's only like 7 different beam angles that it's working on. So the way that I'll do it, my DVHs may not be perfect right now. And that's okay, because I know I only have about 7 beam angles in this course optimization. I'm mostly gonna, in 1 and 2, I'm gonna optimize for my organs at risk. My shoulder may drop even slightly more than this. That's okay, I'll let it drop a little bit. In step 3, now I'm basically, so what we wanna do is start getting these MLC openings moving around the organs at risk. So it's moving around the kidneys, it's moving around the duodenum, it's moving around the rectum and bladder. And it's these coarse motions that we're figuring out. By the time you get to step 3, you're just fine-tuning the MLC positions, fine-tuning the dose rate, and you can bring the shoulder up and bring this tail a little bit down. So we can fine-tune our DVHs without our organs at risk moving at all in step 3. The same concept should be true on all planning systems, just done in slightly different ways. Again, you're looking to slowly push your local minima until you get as close as you can to global minima on your optimization algorithm. So in Eclipse, again, we've got this nice tool here that you can visualize stuff. You'll see that I really won't use this. So I'm going to explain to you all just looking at DVHs, because not everyone is going to have this. But you should be able to view it. You should be able to know exactly what you've got just by looking at these DVHs. So I'll actually put my rings on as well. So my rings look like this. So this means that I've got a pretty conformal beam, pretty conformal dose distribution. So by the end of the optimization, my rings should look pretty similar to this. And that should mean that they're pretty tight around the PTVs. So I'll keep this in mind, what these rings sort of look like, and we'll try and make them look like this again at the end. As we're pushing organs at risk, these shoulders might drop, and these max doses might go up. That's okay. We'll pretty much just push organs at risk until these move slightly, and then in step 3, we'll move them back up. Okay, so I'm going to take these rings off for now. It's going to take me longer than an hour with how much I'm talking. So here are my CTVs, GTV1 and GTV2. All right, everything looks pretty good. I've leveled off here. I'm not going to do much more. So while I'm still in really coarse 7 fields, I want to start coarsely manipulating my MLC patterns. and that will be done with my organs at risk. So we'll start with the ones in the superior portion. So it's not a complicated PTV up there. Should be able to handle it quite well. So we can look at the kidneys and the duodenum. So here's the right kidney. It's got a mean dose of 1,000. Let's drop this to say 700. We'll put 150 on it. And we'll see how this drops and see what happens to our shoulder up here. You can see it dropped really quickly, really easily, and it didn't really affect the shoulder. It's dropped down, it dropped about 2 gray. We'll do that with the right kidney. I can find it. Sorry, that was the right kidney. Left kidney. This one's at 1,100, so let's put it at, say, 800, and I'll do all my organs at risk at 150. Again, we'll look at this DVH and the shoulder. You see it dropped something here a little bit, but then it went back up. It sort of fluctuate a little bit. So this is sort of the game that I'm going to play. I'm going to keep dropping organs at risk while looking at shoulders. And I don't want them to drop too much. If they start dropping too much, it means I'll probably push these. I'll let it alone. I'll let it move to the next step. Okay, let's do the same for this middle bowel. Let's show that one at 27. Let's drop it to 23. Sorry, I was going to do the duodenum. I'm sorry. That was another one up top. 25. Let's drop it to 22. 150. And we'll watch it work.
Adam, when you're watching the PTV shoulders drop, when you do this, is there a limit? Like, how do you quantify, yep, the shoulders have dropped too far, I need to go back?
The best way of knowing that is actually looking at these values here. So I pushed this to 22. It's all the way down to 2230. That means I can still easily push it more. But if I look at, say, the kidney, oh, this one looks good. 700, 750. I think I can push it more. I look at the right kidney. Sorry, I keep saying right. Left kidney. This one's 1 gray high. So they're all doing pretty well. If they start being like 1.5 gray difference, I probably won't be able to push much more. Other than that, it's sort of a visualization. You don't want it to change too much from your original, but you'll allow it to change a little bit. I think you'll get a better idea the longer that we go on. So in this case, this one's only 50 centigrade away. So let's change it a little bit more. 600. Let's do the other kidney. 750. And the duodenum, which is super close. Now let's make it 1800. Now we'll watch it again.
And you're just playing with the mean dose. You don't do anything with the uppers, or maybe?
Yep. I just play on mean right now because I only have 7 beam angles right now.
Yeah,
I'm not going to worry too much about this maximum here.
Yeah.
I'm going to struggle a little bit. I'm mostly trying to just fine tune, you know, how the MLCs are going to move, because once you sort of establish them early on, then you start fine tuning more and more and more. By the time you get to level 3, the MLCs are completely set. All you can do is fine tune them a millimeter or so here and there, right? So here's where I want to mostly fix how my MLCs are, fine tune, finished product. That's the idea. And you can see it drops down pretty well. My PTV is still there. It's not getting affected. So I'll even drop it a little bit more. And this kidney, you can see I dropped it 50 centigrade, but it didn't really change much. I'll leave it alone at the moment. And this kidney is doing all right still. Drop it a little bit more. Okay, so let me move to some other organs at risk. It's going to take me longer because I'm talking so much again. So I'll move a little bit more inferiorly. So let's do this middle bowel. Look at that. 2400. Again, all of them at 150. See how this goes. I optimize one organ at a time. That way I can hit a local minima for each organ and let the PTV go back to where it was. And I can also tell, okay, which is affecting the PTV. So if I optimize 4 different organs at the same time, my PTV drops. Well, I don't know which one I changed, which affected it the most. So here you can see I hit 24, but it's only at 26.5. Means I probably can't push it much more right now. The other ones were getting much closer. So I'll move to something else temporarily. Let's try the rectum. Move this to 24. So I actually do most of my work in level 1 and the first part of level 2, and then the rest is going to be fine tuning. And let's do the rectum was super easy to achieve. Let's do the sigmoid. Again, I'm ignoring the screen. I don't need the screen at all because I can see my DVHs. I know what my coverage is. If I'm ever curious, put my ring on. The ring looks the same as when I started. So I don't need this screen at all in order to see what my dose distribution actually looks like. I can visualize it just with DVHs. Okay, let's get the bladder. They're all sort of in the same area. This one. At the beginning, I usually drop about 4 gray at a time. And my PTVs are looking the same when I started. And I'll look at the other ones that I optimized. This one hasn't done real well. Sigmoid is getting a little closer. Rectum, you can see it almost matched it. I can go a lot further down, achieved it really easily. It pulled my sigmoid. Let's see if it goes, pulled my PTV, see if it goes back up. It should.
Well, the thing is, it's a good idea that you're putting the CTVs just to show, because you don't want those to drop.
Right.
And you have, of course, the PTV is what you care at the end, but if you see that dropping a lot, that means that structure is not, it's going to ruin your plan.
Right, right.
That's what visually is nice to have them there.
Yeah, exactly. And again, all of these will tweak at the end.
Right.
Back to exactly what we want. Again, rectum, it achieved it quite easily. I'll go down another 2 gray. I forgot my bone marrow. Let's put some constraints on this. Again, this huge volume of radiation. Let's
do you have constraints for the bone marrow, or just you use Alara? Like
both. I had constraints at my previous hospital, and I'll be honest with you, it's been so long I've forgotten what those constraints are.
Yeah.
I think it was like D10 less than. I won't even say it out loud because I might be wrong. In this case, it's going to be as low as reasonably achievable. Yeah. Again, you've got GYN cancer, which is quite aggressive. We don't want to break a weak break in treatment. So if it's concurrent chemo, we want to keep those blood counts up. That weak gap could be a big difference. Okay, so let's look at the femurs are max doses, so I'll worry about those later. Again, as I fine tune, they're a few millimeters away from the PTVs. So the bladder is close. Rectum's close. Okay, and I've about pushed it as far as I can in this step, and I'll probably go to the next step, especially for time's sake. Again, these spinal cord and PRVs, these are more max doses. I'll worry about those more later. Okay, so now I've done enough optimization, especially given the time. So this is already leveled off. So I'll hit play, and I'll allow it to go to the next level. And basically, we'll just repeat this exact same process in all the different steps along the way. Usually all 5 of the level 1 steps, maybe the first of level 2, and then we'll fine tune it when we get to beginning of level 3. So I'm actually already, it's funny, I'm in the very first step, but I'm probably pretty close to what I'll have for my final objectives, minus the fine tuning. Okay, so it gets worse for a second. You can see the error goes up, and that's just because we added more degrees of freedom, and it does an interpolation between the new gantry angles, and that interpolation will be, not ideal. So it's going to fine tune in between those original 7 gantry angles, make that interpolation better, and we'll actually get some improvements. So I don't start optimizing again until this levels out, right? I want it to achieve the local minimum, level out, and then I can start pushing organs at risk, right? I want the algorithm to fix everything first before I start optimizing more. So we'll let this level out, and then we'll start tweaking organs at risk again. While this is optimizing, I'll show you a couple other DVH things I put on here, which I didn't explain before. Let's see, so I've got this, we'll start with like the PTV-50. So I put 95, so my D95, I'll want to be prescription 50 gray. So this is, I'll always have it at 0, but it just shows me what it is. If you don't have this value, you can just put D95 50 gray with 0. It'll show a little point here, and you'll just be able to visualize it and make sure that your DVH goes over that point. That means that your D95 is 100%, which is what I want in my case. Again, your doctors may be going by different protocols, may want something different, but the concept is the same. So you can either see the value here, you can visualize it on your graph. Either way is a viable option. I've done something similar for my CTVs. This is a dummy here. That way I can just see, because sometimes 100% will be something really low, but maybe 99.8 will cover 100% of the CTV. So in this case, for example, you can see 99.2% of the CTV is covered by prescription. So this is just a dummy thing. So I've got a few of these dummy things, but they're helpful. Okay, this is come close to flatlining. That's good enough for me. So I'll look back at my organs at risk. We'll just go through all of them. How did I miss my left kidney? Sorry, guys. I don't know what happened.
We're changing something else for the left kidney.
Oh, I've got a kidney here. I've got two left kidneys.
Because you were using the RA output.
All right. I could have sworn I was doing it. Okay. Not that crazy. Okay. So let me get rid of this before it confuses me. Okay. I'll just start tweaking again. Now you guys are probably getting bored on the other line. Like Adam, we get the point.
It's good to watch.
Yeah. Okay, this one's close. Within half a gray, it means it achieved it pretty easily. Drop this to 15. Again, I have more degrees of freedom, more beam angles and optimization, so I'm able to drop things, still maintain my PTVs. This kidney. You can see things aren't changing that much. Like I said, I've done most of my optimization already, and that's step one. Rectum has gotten close. This one should drop more. That should drop pretty easily. But notice my PTVs actually look pretty similar to what I started. Maybe dropped this one's dropped a little bit. This one's dropped a little bit, but it's okay. And we're visualizing these dose differences here. And again, if you don't have this value to visualize, you can visualize, well, you can't do it with mean, but you can actually look at your DVH and get an idea where things are. You can put upper limits and actually look at your DVH if your planning system doesn't show you actual values. So there are multiple ways to achieve things. This right kidney, which is further away, we should be able to drop that a lot. Again, I'm well beyond tolerance, but if I can drop it without affecting my PTV, might as well, right? And these, again, I'll get later. Okay, so I'll see if I can change anything else. You can visualize your rings again. They haven't changed, right? They look the same. Again, I don't need my picture of the isodos lines because I can see my rings. Nothing's gotten too close, so I won't push anything anymore. They're all a little bit far away. This one, maybe I can push a tiny bit more.
You said like core and Cora, you're gonna do it later on, no?
Yeah, I'll do it probably in step 2.
Because the doses is almost there, but
yeah, they're closer to my PTV.
Yeah.
So it's something I can fine tune a little bit more later. All right, I think we're pretty good. This is already leveled off, so I'll move to the next step. All right, I'll let this just level off.
If you were doing this plan clinically, would you fast forward through this like you have been, or you would spend longer?
Maybe I would spend a little bit longer, but this is approximately how I would plan it.
Mm-hmm.
I wouldn't take much longer, because again, I can see where it needs work. So in each step, I'll just take a quick look. So bone marrow, you can push it a little bit. Bone marrow is really tough. Again, we just want to sort of keep it there. You can push it. In certain cases, I've really pushed it. And then I would just go through each one again. So the bladder's gotten close again, so I can push it down. This one, it's like a gray off, so I'll just leave it. This one's about a gray off, I'll leave it. This one's a gray and a half, I'll leave it. One gray. I mean, I could keep pushing a little bit and have this drop a little bit. This case, it's 2570. I'll push it more. It was only like 0.7 gray off. I think you can do better. Yeah, so maybe clinically I would push a little bit harder, because my shoulder has really not dropped much, but I'm pretty close to how I would do this clinically. Okay, it's leveled off. I'll hit play again. And I'm purposely not looking at this screen over here, because a lot of users won't have it. And I think it's good to not rely on this screen as much as just understanding your DVHs and what they mean. Look at the rings again. In step 3, I'll probably put a max dose right around here. See, there's just this tail of hot spot. That means that there might be a few little hot areas coming out of my PTV. Maybe we can just truncate this tail slightly. But it's not much. It's just really a tail on this ring.
You can expand your DVH window so you get rid of that other one.
Yeah.
If that makes it easier to, if it makes it easier to see your DVH.
It does, but Claire,
To me, my old eyes, I can't read it.
I've gotten so used to looking at DVHs as a square.
Ah.
That,
All right.
I know what they look like in this view, and when I expand it, now this is completely
looks worse. Okay.
So I'm just gonna continue on. My organs at risk are close. I think you get the idea of how to optimize on each step. I could honestly keep doing that, slightly pushing them all the way up to the end of step 2. That's the idea. Each interval I would pause, slightly move each organ at risk until the end of step 2. But in this case, I'll just let it play through, just pausing it long enough to level it out. And then when I get into step 2, I'll just fix some of these max doses and spinal cord stuff.
So Adam, you're saying right now all your organs at risk are under tolerance?
Yes.
Great. Okay.
Okay, here, jump to step 2, much more degrees of freedom. Again, it's doing this interpolation and then fine-tuning. So we'll let this level out. I'll fix a few of the more max dose-like things. Same thing for max doses. So for things like head and neck, so if I'm doing, say, nasopharynx with optics involvement, optics take priority. So maybe I'll have, say, a PTV 59.4 going into the optics. Well, I would cut out PTV 59.4, say 3 millimeters away from the optics, which I want a max dose of 54 gray. And then I would limit my PRVs to 60 gray. But I would do that fine tuning of those optic structures just basically in step 3, because again, that's this small movements of the MLCs can finally carve out little bits of dose, say around the optics, while keeping dose on the PTVs. So a lot of that step 3 is just for fine tuning dose around small structures. Same thing, I might have like a really hot brainstem or a spinal cord, and then in step 3, I'll just fine tune it, and I might drop it 7, 8, 9 gray max dose just by fine tuning of MLCs without affecting PTV coverage. Again, it has to do with making your contours correct, so that there's no overlapping arguments. So for example, again, in head and neck, I would use that same 5% per millimeter for sort of all around, 10% per millimeter close to structures, and I would know exactly how far do I want to carve a PTV, say from a brainstem, so that I don't have conflicting arguments in my algorithm. That way I know I can get brainstem max, exactly what I want, and still get all my coverage of PTV. Otherwise, this becomes some weird shoulder, and you don't know if this lost dose is close to the brainstem or if it's just in the center of PTV somewhere. So separating out your PTVs from your organs at risk as much as possible on these critical ones where organs at risk take priority is really important. If you do your contours properly and you use those sort of 10% per millimeter, 5% per millimeter as sort of a rough idea of how to subtract, you should be able to do a pretty good job first try. All right, I'm going to put in these max doses and all my organs at risk. You can see some are closer than others. I'm not going to worry about these too much because my ring and my NTO are already sort of working on these. So if they've got a max, it's probably a small area somewhere. But I'll put these in anyway. Not as worried about these because I know my ring and my NTO are sort of doing that trick already. So let's look at the spinal cord PRV. So this, I'm far away, I can drop that quite a bit. And my spinal cord itself should be a few gray lower than the PRV always. So if I put it at 34, I'll put this at say 32. And for these spinal cord, I can increase the priority quite a bit. I know it's not going to affect my coverage. You see nothing's moving. I'm just lowering these only. I'll just keep moving them. They're moving pretty easily. Nothing moving up here. Okay, and spinal canal PRV, this was sort of overlapping. So I'll put a high priority just that this gets down a little bit, but I'm more concerned in this case with this doctor. Again, it depends on what the doctor says, but this is just how I'm optimizing it here. The process of optimization is what I'm teaching, not necessarily the actual constraints that I'm reaching. And then this one should be able to drop lower. So I can see that this is a tail for the actual spinal canal. The PRV, it's a tail as well, but I know it reached into the PTV, so I won't drop this anymore. But this tail, maybe I can cut it off somewhere around here. So I'll just go to the spinal canal only. And I'll up the priority quite a bit. Again, I know it's just a small thing. It's not going to affect my PTVs. That's here. Hopefully I'll start getting rid of this tail. See the tail getting removed slightly and not affecting my PTVs. Okay. I'm going to go ahead and play it. I think we're getting the idea. And I'm going to pretty much just push this along to step 3 so that we can all see how I'll just fine tune those PTVs. Pretty close to a clinical plan.
Yeah, plus for most of your ORs, you're way low from the criteria, so just very good actually.
Yeah.
So like you said, it depends the physician, it depends the patient too. So how much?
Yeah. I mean, I got to the point at my last center. My doctors were I trained all my physicists and dosimetrists in this method of planning, and the organs at risk were getting so low that we would have doctors in some cases, add an extra fraction or two. And they would say, we're getting no complications. I mean, we would start escalating things and having overlap of organs, even lower doses, and our patients were just getting really low toxicities. So in particular cases where disease was a little bit more aggressive, our doctors were happy to escalate because the toxicities were just so low. Okay, this is close to leveling out. It's fine. I'll let it go. I want to just get to step 3 so that we can see this fine tuning. And if done right, and if you sort of get used to this process, the same concept should work on any case, whether it's multiple SIB, if it's pelvis, if it's head and neck. The same concepts work at every area of the body. And so the idea is, especially if you can get scripting to get these organs at risk, the planning contours, sort of the optimization contours done quickly with a script, and you follow the same template, you can really drive your throughput, limit the number of beams, drive your throughput for patient plans per dosimetrist, and hopefully get high quality plans for your patients.
Yes, and this is like kind of like the worst case scenario for plans, like when you have like multiple, SIVs. But let's say if you have a lung case or a brain case, which is just one PTV, is different because it's only one PTV you're watching, and
Yeah,
then just work a lot on your ORs. And
yeah.
So this is that's a probably here you have extra structures that you need to.
Yeah. Exactly. And when you're doing a head and neck case, especially one with optics involvement, sometimes you got 20 organs at risk that you're one by one tweaking.
Yeah.
So it takes a long time, but if you do it in early fashion. Yeah, exactly. If you got 3 or 4 SIB, all those organs at risk. But the good thing is, if you just do it slowly, systematically, even if you have that many PTVs, that many organs at risk, it doesn't get overwhelming because you just do one at a time.
Yeah, I agree. And that's a great technique, actually. See how you started. You started with the PTVs and the Rhines, and then one-on-one, you were like, it's basically just to be patient and consistent.
Okay, so what I'm going to do is I'm going to work on these shoulders of our PTVs. So what I don't want to do is fix my PTVs and then my organs at risk shoot back up, all that work I did on organs at risk. So what I want to do is lock each organ at risk down. So I'll do one at a time. So here's my right kidney, and I'm just going to put these locking structures on here. So I'll put 2 points per structure, not pushing it, but just locking them in place. I'll put them at priority of 300. So I'm not pushing anymore. It's not doing anything. It's just not going to let it move. These femurs, sorry, I even forgot to put anything on them. Again, my ring sort of did that trick anyway. So next we'll go to this sigmoid. We'll put a couple locking structures on here. Usually a lower dose, a higher dose one and a lower dose one. And I'm just going to lock each one into place. I do this after it's leveled out. I'll do this for each one of my organs at risk. So if I didn't put these locking structures on and I just fixed my shoulders, then these organs at risk would come up. And I don't want that to happen. If I push an organ at risk too much and I find that I can't fix a shoulder, sometimes I'll just go in and I'll relax one a little bit and I'll see my shoulder will just come back up.
Is it intuitive to know which one you should relax if you need to do that?
Yes, that's a good question. So you won't see it on this case, I think, because I haven't pushed anything that hard. Sometimes you'll know ahead of time, like if I pushed my parotid super hard, it probably came from a parotid, not in a pelvis like this.
Okay.
But, otherwise, what you'll see is if you turn on all of your locked structures, so right now I've locked all of these. This one's overlapping, I won't show. And you'll see all of them after my shoulder just won't move up. I can't get this thing to move up. I see that all of mine are still below the lock structures, except for, let's pretend this one came up here. It went slightly above it. It moved slightly. That means it really, even at a priority of 300 here and here, this one wanted to move. That's probably an indication that this is the one that's hindering my PTV shoulder. So then I would just, if this moved, I would just move this up. So let's say, sorry, I'm just going to show you. These are at 0 priority, so they're not affecting anything. After moving my shoulder, after optimizing my PTVs, all of them look like this still, but this one looks like this. I would say, okay, this one is the one preventing my PTV. So I wouldn't lock it because my shoulder is still bad. I would move it here. and here. And then all of a sudden, you'll see the shoulder will just move right up. So you can easily tell which one is causing the problem. I'll lock this one in. I'll lock this one. Okay, almost ready. Oops, and let's not forget our bone marrow. And we're mostly worried about the low doses of bone marrow, not the high doses. Okay, we've got all of our organs at rest locked in, and we're ready to go. Take a quick visualization. Our rings still look really good. I'm not going to mess with those. Now, let's start with PTV-45. This one's the toughest one here. So we have our helping structures. Let's check out the edges. Whoa, look at that. The edges are struggling more than everywhere else, just as we thought. So I'll just raise these priorities. I'll add in an extra one, that's 98%. And we'll put in this one as well. And let's see how this works. So it'll be sort of a combination of raising these, trying to limit the high doses as well. And our organs at risk should not be moving at this point.
So normally at this point, you will be using the edges, the corners, and the mats, correct?
Yeah, I can typically my PTVs will go up to around 300 at this point.
Yeah.
Yeah, the corners actually aren't bad. It did pretty well, but we can still push on it. And we can just push on all of them. So we never even use this 98% of our and we can push our CTVs. That'll also help. So you can see we're almost to 45 gray at 100%. And that's what this little dummy structure is for. So you can see 99.9% is getting prescription. So I don't need to worry about my CTVs anymore. And this one, a little bit. Okay, you see how this little dummy structure works? So I actually have .7% of my CTV is getting prescription dose. So this little thing doesn't really bother me that much. At the minimum is actually 44 gray. That's just 0.3% of it. My other PTVs, so let's see this TVH PTV, we are at 44.4 gray, so it still needs to go up quite a bit. And then it's just this process of fine-tuning all of these. Again, 95%, D95 is at 44.5. It needs to go up another gray. And same with this one, needs to go up another gray. And here's where, I'll actually mess with these values a little bit, my optimization doses. I might push these up like half a gray just to push this up. Some people can have different methods. This is how I'm going to do it. Or you can increase these values. So maybe I'll do both. Increase these priorities, then maybe I'll mess with these doses by like half a gray here or there. The other thing, you can see the body is still working harder than everything else. That's my NTO. If this starts to drop in priority too far down, that means I could have dose spillage. So I'd probably up it in this normal tissue objective. So if I get up to like 300 priority on these things, then maybe I'll have to up this normal tissue objective as well. Or if you don't have that, then you would up your ring values. The GTV, just to show you what these things mean, this is my dummy structure. So 99.5 is getting 52.5. So let's up this as well. Both GTVs. Okay, I'm starting to get pretty close. So PTV-55, 95%, almost there. PTV-50 is almost there. And 45 is still like half a gray low. So we'll start by raising these priorities. If that doesn't work, then we'll slightly change this dose level.
Adam, how much time do you spend kind of chasing your tail for these super small changes when you know that you still have to run the leaf sequencer and it will change the doses again?
That's a good question. I'll try and get it right now and after. That's a good question, though. Maybe I shouldn't chase these tails that much right now. But I still want to fine-tune this and these max doses before I get into level 4. So I'll sort of do this process twice. So my max doses, let's see what this looks like. Here's my 50 max. You see it turning on and off. This is 5% at 105. This is 105%, 5%. So it looks pretty good. And my 55 turning on and off. Again, this is 105%, 5%. Looks pretty good. I'm not going to worry about lowering those right now. My 45 is probably not going to look great. This is, what is that? Sorry. About 9%. I really want to get rid of these 10% hotspots as much as possible. And it's just sort of a tail through here. So if I turn some of these off, so you can see it better. Here's that 45 max. See, it's just got this tail. Let's knock it down around here, right? I just turned them off so that you could see what I was looking at. That's my 45 max. And I'll put a big priority and just knock out that tail. I can put a priority on this that I didn't have before. Keep my DVH on. So it's still pretty close. You can see it visually, it's pretty close. Something else that you could also probably do a normalization once the plan is actually done. So I haven't seen this tail gotten rid of yet, so I'm going to up this even a little bit more. Again, these tails, you can put high priority on these things and it won't affect it that much. You can see the way that each DVH drops should be about the same. Now some of these are different because this is a CTV that includes GTV, but the things that are excluded should have about the same slope, right? And my edges are still bad. This needs quite a bit of improvement. You guys get the idea. I mean, I could fine tune this. I've increased my PTV so much. I'll increase this a little bit. Here.
So that's another benefit when you say that you were lowering your ORs, let's say in case you need to renormalize a little bit, so you have room there. So
Yeah.
you know that, which sometimes it helps. It's just that you need just to meet your D95s for your PTV. Yep. And when you lower that much the OR, so you know that you're not going to exceed anything there.
Exactly. So that was my max bowel loop. Sort of talking a lot and maybe not paying enough attention. So I think we're getting close. I'll go ahead and let it finish optimizing. I'm right around my D95s for everything. My GTVs have pretty high coverage. They're close to that 107% hotspot that my doctor would have wanted. It all looks pretty good. And you can get the idea. You can fine tune, fine tune, fine tune. We'll let it go. We'll let it go to step 4. We'll let it do intermediate dose where it calculates you know, with the actual algorithm, then we can fine tune some more. But that's the idea. So if I can turn on my organs at risk, you'll see how they haven't moved. Bladder has a little bit, so I can move it a little bit. Hasn't moved much. Maybe that's affecting my shoulder somewhere. Duodenum, same thing, slightly. Hasn't moved much. I'm not worried about that slight movement. Let's let it not affect the shoulder. Kidney, same. Let's not let this one affect the shoulder. But it's barely moving it at all. Middle dose. They're still really good doses. Does this answer your question from before, Claire?
Totally. Yes, it does. Thank you. It's a good example.
Yeah, this is a good technique actually, because you can clearly see what is causing you the problems.
Yeah, exactly. And you never really need a picture. You can only use DVH.
By the DVH, yeah. And I think right from the beginning, I mean, when you have cases when, for example, if there was a lot of overlap of bowel with the PTVs, you know that the bowel is going to be a problem. So
yeah.
you know that from the beginning. So
Yeah. I'll have to fix this thing. I'll wait for it to go one more step. But at least the actual canal, you know, it's low. And the spinal canal actually has a higher tolerance than the cord. Just gonna move to the next level. Come on. Watch pot never boils.
now.
Okay, I'll just let it level off. I may not get everything just perfect in this plan, just because, you know, I don't want to waste an extra 20 minutes of people watching this when you'll see the idea of how you can fine tune these things to get them perfect, right? And you could fine tune all these little things even more. Again, we'll do the second fine tuning iteration after the intermediate dose. But I think the concepts have been taught. Maybe even if we don't get the perfect plan by the time we finish. So again, my CTV is 99.7%. This one's both of 99.7% covering. Okay, this is leveled off. So we'll move finally into step 4. And again, guys, I've got a year of rust on my planning skills. So
You're good, actually.
I don't see any rust.
we'll just let it move on to step 4. No, I mean, I'll look through this just to show you. I mean, it looks pretty conformal. I haven't changed these doses to even look at things well. And again, we could try and play with these max doses a little bit more. This 55 max a little bit more. You know, all of this is part of the fine-tuning process. And I'm only going to play a little bit more just to show you the idea. Okay, I'm going to play it, let it do the intermediate dose, which for pelvis, it shouldn't change too much. If you're doing something like in the lung, it might change quite a bit more. It should just be small changes. Any other thoughts or comments? We talk about other sites as well. Anything that wasn't clear?
Oh, it's all good. Actually, like you said from the beginning, when you set up that's what the setting up the contours is so important at the beginning, because see, you never left this optimization going back and maybe, oh, I need to create this other contour to fix this and that. So you have everything. So it's just a question of fine tuning and know what you're doing. So that's really important, I think. And especially for these cases that, like I always said, you have many dose levels and organ. For cases that you have one PTV, is a different story. I mean, it's a little more, you're watching one PTV only.
And again, you know, if this plan is not perfect, I would just jump right back into the optimization and work on this fine tuning stuff again. I wouldn't create any other hot or cold or any other helping structures. I'd use exactly what I have. I would just jump back in and fine tune these shoulders, fine tune the tails, fine tune the ring. That's all that I would do. So even if I had to do a second iteration, you're probably looking at, you know, 15 to 20 minutes to just fine tune something that you didn't see on the first time.
Yeah, because with the extra structure that you can create, you are chasing things, and then you fix in one place, but then it goes somewhere else, and then you keep adding and adding.
Yeah.
I mean, it worked for some cases. I mean, I have to say that we do use them, not all the time, but for some cases they're useful, especially, for example, when you do contours out of isodoses, and you just can fix something very quickly that way. But
and there are, you know, there's no, like we always talk about, there's no perfect way of planning, right? We all have our different methods. We'll see a few different methods throughout this RCC course, which is great. So you can get ideas from different people. I was one of the people commentating on a couple other plans, and I actually learned a couple really nice things that I'm implementing into my own planning. So you pick up things from different planners. I think the idea is try to be as efficient as possible and as high quality as possible.
And methodic, you know, when you know exactly what you're changing, when you're changing. So it can get confusing though.
Yeah. Again, you know, this may not be the best method. I think it's a good method. I've taught it to a number of people that have picked it up and have been incredibly happy with their planning after that. They're quick, they're good. Some of the students have surpassed their teacher, which is always a good thing.
Yeah, that's always the case. But that's a good thing, you know. You gave the speed.
Version 2.0.
Exactly. We're not in that version anymore. Or version 1.0, so that's it.
Yeah, exactly.
How often do you find that you get a plan that you're just not going to meet all of the criteria, or it just doesn't happen?
When I was planning a lot, never, honestly. I mean, outside of, if there's an organ at risk that, you can't achieve it, you can't achieve it. Okay, that's fine. But if I tell the doctor, okay, I can achieve a lot at the expense of PTV, but I'll still treat CTV, then I will achieve it as well as possible. So whatever my clear instructions are, there's never been a plan that I haven't been able to reach with this method within, say, 2 iterations. So this initial plan, and then maybe a slight fine tuning of a couple max doses or something that was just slightly off that I went back into to tweak. And the same exact process, again, I'll use for like nasopharynx with 3 SIB and optics involvement and close to cord and brainstem. You know, very complex cases, but methodical contouring with those 10% per millimeter for smaller organs at risk, 5% per millimeter around structures. I'm able to get really good plans, you know, talking about within an hour 15 or so. Now watch, I'll close this plan. It'll look like a disaster, but.
I think it's tricky when you have retreats. That's when, because the doctors, they have expectations and you might have guidelines, but then that's what I think you go through the wall of, okay, this is impossible for me to meet retreat cases, and yeah.
Yeah, so there's
make decisions with the doctor though.
Yeah, and I think there's a difference between not being able to, say, treat the patient and not being able to achieve a plan. So you can always achieve a plan.
Yeah, yeah.
Right?
Yeah.
But you may not always be able to achieve what you need to for that patient. So I'm quickly going to look at this. Here's my D95. It's at 45 gray. That's good. See, the edges is a little bit low, but I'm still reaching the D95. I'll leave it alone. PTV-55, that's the one that looks a little bit low. So even if I didn't have this value that shows 54.5, well, I can see it's 54.5 if you don't have that tool. So let's raise that just a little bit. If this doesn't work, I can slightly increase this dose just to bump it up. I think I'll get it though. PTV-50, I'm right there. Let's just bump it up a little bit. GTVs are 99.5 is getting my 7% hotspot. This one, again, it's pretty darn close. Yeah, it's like 99% is getting my 7% hotspot. I'll leave these alone. You know, I could keep going. I could fine tune these max doses even more, lower hotspots. You know, you could continue this for another 10, 15 minutes if you wanted to, just fine tuning shoulders, fine tuning hotspots. But I think it looks like everything's just about there. Okay, I think I'm splitting hairs at this point. I could fine tune it more, but I think everyone gets the point without wasting any more time. This one's D95 is right on. This one's right on. This one's slightly low. I could fine tune it more. I'm not for time's sake. I think everyone gets the idea, right? So I'm gonna go ahead and finish this off. Again, I could lower these maxes a little bit more if I spend another 10 minutes or so. I could lower each max and make all these shoulders, you know, a little sharper. These high doses a little lower. I could mess with this edges, contour some more, but I think we're about where we need to be. So I'll just finish it off. And then we'll quickly look at the isodose lines on the plan. And then we'll end the call. Okay. Finished. Save it. Do a quick calculation. We'll just look at the isos lines and see sort of what, hopefully what a final plan looks like. Right around, in this case, 2 arcs. I think it was 740 MUs. You can tell that it's highly modulated, probably lots of small beamlets.
Just a quick question. I noticed that you're using 6MB. Do you think that you could have used a higher energy on these cases?
Oh yeah, that's a good point. So I think a 10 MV would have worked great.
Right.
Probably better. I think I just took whatever
is there. Yeah, it's good.
The previous amount of use. I didn't really even think about it much, to be honest with you. But that's a good thing to point out to everybody. So for pelvises, for prostates, I think it's fine to use 10 MV.
Mm-hmm.
If I'm going to be planning something in the lung, I'll use 6 MV.
Yeah,
and
through 6MB.
And the reason, there are a couple reasons for that for anyone listening to this. For the lung, one, you have better buildup into the sort of lung portion of the PTV with 6 MV than you do with 10 MV. And then your beam modeling will be better. For your lateral scatter, your model can better predict 6 MV than it can 10 MV, just because the secondary electrons will scatter further distances with your 10 MV, which is harder for your model. Now, if you have Acuros or Monte Carlo, either one will do a good job. Or if you're doing something like AAA, 6 MV will be a lot more accurate, your model. Collapse cone is somewhere in between AAA and Acuros in terms of its ability to model that scatter. All right, let's check this out, see what this looks like.
Adam, quick question. Why do you name, what is RA when you name the...
Yeah,
it's just,
what that means is that I need to watch your PowerPoint presentation that you're going to give later.
Okay.
And then I'll name them properly.
That's okay. I just was wondering what, if it's a, yeah.
No, it's bad naming by me. So don't follow these names, anyone watching. Watch it. Cesar is going to give a great lecture on all the contouring that we've done today, in addition to regular organs at risk contouring. So listen to those instructions, not what I've labeled here.
Sometimes if we have residents that do the contouring, they'll put their initials before the contours. So you know that they're not necessarily approved clinical contours.
Yeah.
But that might not be the reason.
Okay, so here's 95%. That's the first thing I'll look at. And pretty conformal. Not missing any PTV. Almost no spillage. That's pretty good. Moment of truth. Let's see how our 100% looks. Should cover CTV, which it does. Quite well. A couple holes, but we could fix that with normalization. Let's look at this. Oops. This is our PTV-50 node. It's covered quite nicely. The D95 is definitely there. If we look at 95%, that node, it's there. I'll look at 7% hotspot, covering that GTV mostly. Looks pretty good without spilling into the rest of the PTV. Let's look at our PTV-55. Covers it quite nicely. We can look at 7%, covering just the node and not really anything else in the PTV. So let's look at is right around 9% hotspots in my PTV-45. It's a little bit warmer. So maybe here's where I didn't spend that last 10 minutes fine-tuning the hot parts of the PTV. Right, so I would probably cool that down a little bit. And I think I would have done it if I had spent another 10, 15 minutes just working to cool down those little tiny spots. Okay, I look at 50% isodos line. So I always look at this with any plan. You can see it bowing around. So this is actually 50 gray and going all the way up to 59 gray. Sorry, going up to 55 gray about. It bows nicely around the kidney, around the duodenum. Here's PTVs right here. So this is dropping 50% this quickly. This is quite impressive, I think. Around the duodenum. You can see it dropping on the bowel, on the bladder, more bowel, around sigmoid. This is all 50%, which is pretty impressive for just 2 arcs. Here it is, bending around the rectum, around the bladder. It bends all the way through the rectum, all the way through the bladder, which is a sign that it's been pushed well. Pushed all the way. We could even look at 1,000 gray, 1,000 centigrade up near the kidneys. See that they're still being spared nicely. Okay, so if I were a plan reviewer and I looked at this, the high dose, the low dose, I'd say it looked like a pretty good plan. And the planner was probably able to do it in about an hour, 15 minutes.
Great.
So there it is.
Great job, Adam.
Thank you. I hope it's really helpful. What do you say, Cesar?
You passed the test.
Good.
Very.
My video is off. I was sweating bullets over here.
You want to show like quickly like the DVH, just 2 seconds, just to see.
Yeah, sure. Yeah. The bone marrow. Here's the 2 CTVs. So 45 gray is here. They're both getting 100% coverage.
Yeah, good.
CTVs. I'll just look one at a time so we can see. Again, I'm not going to analyze. There's overlap in different PTVs with the bladder. Let me just pull up these GTVs. This one, 7% hotspot, 97% coverage. This 7% hotspot is 100% coverage. So we did 5 different dose levels in this plan, even though some of them were pretty small. Here's the kidney dose, the mean of 8 gray. We have to look at our DVH PTV-50. Here's 50 to 55. See if I got it. Yep, 96%, 96.5% coverage for this one. PTV-55. I think I might have missed this. I think I just missed PTV-55 at 93% coverage, but you can see how close. 95% coverage is, 23 centigrade low. Just a small fine tuning. The right kidney, you can see how low it was. Less than 5 gray mean dose. Spinal cord PRV, max of 31. Spinal canal PRV. This is when I said that we could lower it. I just ignored it in those final steps. We could have fine-tuned that down to about 44.5, just by spending that extra 10 minutes. Spinal canal, though, is at 39. Had that little bit of overlap. Spinal cord, low, 27. So yeah, you want to see anything else?
Oh, that's good. Yeah, just yeah, that was great.
Yeah, so it's pretty darn close.
Yeah, very good.
Sometimes as a plan reviewer, I'll look at how the MLC leaves move. Nice thing to look at. It's always good to look at this to see if there are things that were missed or weird things that happen, or areas where the MLCs were leaving dose where they shouldn't. You can see this is pretty highly modulated for such a big field, which means that you better get your DLG correct on your commissioning.
Yes.
What sort of modulation would you start to get concerned?
It depends on how well I've commissioned.
Yeah.
So at all my centers where I've worked so far, we spent a lot of time making sure that we commission things well. And we would test plans like this, so highly modulated. So typically, if my planners are doing what I want them to do, the plans end up highly modulated. So if your DLG matches what your planners do, then there should be no problems in terms of what you see on your planning system versus what you deliver. If you are seeing some issues, then maybe I would try and reduce that modulation some until I were able to fix that in the sort of commissioning of the beam, or just the small fine tuning, which is usually just a combination of DLG and or dosimetric leaf gap and a MLC transmission to a smaller degree.
Mm-hmm.
Do you guys look at the duty cycle for like VMAT plans, like the sum of the mu divided the dose?
I do not. You can inform me right now if you want.
That's something that
Yeah, that's what we use for our modulation index.
That's what Varian recommend us, to have it like below around 4 or 5. Like
okay,
if
so
you add up the mu's and divide by the
dose.
Yeah, but the dose per fraction.
Yeah.
Okay, so this would be 385 plus 356
yeah.
divided by
I think you're just over 4.
Dose per fraction divided by 1.8.
180.
Centigrade, 180. Yeah. Well,
okay.
It's 4.
So
See, that's good. Because it's what normally 4 is what we normally like below 5 in general.
Okay. Okay, that's good to know.
Yeah. It's just a parameter. I don't know if it's telling you a lot, but it works.
We do it for all of our VMATs. Just as a QA.
Yeah, that's the same with that.
Okay, great. Well, thanks for that information. Learn something every single day.
I know, right? Excellent.
Okay, well, if there are no other questions, I guess we can stop the recording. And I really appreciate your all's time and your input.